Hey Jake, how are you?
Good
Hello.
evening, Rick. Hi, Rick. How are you tonight?
I'm good, thank you. How are you?
Uh, Going crazy. I'm trying to open season for insurance opens today,
Yeah.
so I've been kind of trying to find a decent plan that'll cover me.
Mm,
You know,
mm.
Andy and Zytiga are the ones that are the concerns.
Sure.
Yeah.
Um, I mean, both of them would be covered. The question is what it's going to cost you and whether you can buy the additional insurance. I mean, probably what it means is that you're going to have to figure that it's going to cost you the donut hole, whatever happens.
Yeah. Well, Medicare doesn't cover any of that apparently, and the secondary insurance is what I'm looking for. So I'm thinking I might even go with keep my secondary insurance and also get a prescription plan D. I don't know how that would work, but
Well, yeah, but Medicare does cover it, but they only cover 80% of it.
they
Medicare,
don't cover they don't cover pills.
they don't cover pills, and Xtandi and Zytiga are both pills. You're right.
You know,
Um, hmm,
so you need a prescription plan, a prescription D plan,
right.
and or a secondary plan, which I've already had anyway because I have my wife has to be covered.
Right. Well, the prescription, well, we can talk about this. We'll talk about it on the call because I'm sure that there are people with a bunch of experience on the call, more than I have,
Right.
because I use uh, um, a Advantage plan. But okay, we'll go on. Let's see. So who else is on the call?
Paul Hobson in Australia.
Hello, Paul Hobson in Australia. I see
Hi, Paul.
and I see you're using the telephone this time, eh?
I've got a 5-hour kidney test at the moment, so I'm passing part of the time talking to you guys.
Well, good. Okay, we're always happy to speak to you. You can tell us more about that test in a minute. And who else is on the call?
Tom Guffrey, upstate New York.
Oh, Tom, welcome. Very good to. I'm delighted that you've joined us. This is Rick Davis.
Oh, thanks, Rick. Thanks. I appreciate the emails you've been sending.
It's a pleasure. I owed you one, but I thought I'll wait and see if you come on the call or not. So I'm just putting your name in. You can't see it because you're on the phone, but those who are on the those who are on the computer can see it.
Okay.
And I think I may have put in the wrong person. And Jeff Ledoux. Hey Jeff, we haven't heard from you for a while. How are you? Well, are you there? Maybe he's there, maybe he's not. He shows up, but we don't see much more. And let's see, who else? One other person I think is on the call. Anyone else who hasn't identified themselves?
I'm
No.
identified, but I don't know if you see me yet.
Oh, Jeff, I just gave you a shout out.
Dennis is on.
And Dennis is on from Tucson.
Tucson.
Right. How are you, Dennis?
Hanging in there.
Okay. That's what we like to hear. So hold on, let me put some names in here. Dennis Correa and Tom. There we go. Edit. Okay. All right. Anyone else? No one else, right? Oh, Bill Franklin. Hey, Bill.
Hey, just dialed in.
How are you?
Pretty good. How you guys doing?
I'm doing fine. I don't know about Paul Hobson, who's sitting there in Australia with a 5-hour kidney test.
Ah, that doesn't sound good.
It doesn't. Well, well, hopefully we can make him smile a little bit whilst he's doing that. All right. What I need to do here is I need to open my contacts here. Well, and who is that we heard in the background?
Oh, just now? That's my kids. I should have muted.
Oh, that's okay. How old are your kids, Tom?
Oh, this is Bill.
Oh, it was Bill. Oh, it was Bill. Oh, it's your kids.
Yeah, they're 8 and 9, and they're arguing over their homework.
Oh, I didn't realize you had kids that were that young.
Yeah,
Oh,
I started a little later.
that's okay. We're happy to allow that.
Yeah, I was happy it happened.
Meanwhile, how's your weather there in the north of Florida?
Central Florida.
Central Florida, sorry.
St. Pete on the Gulf Coast. It's beautiful, man.
Yeah, I wasn't sure. I mean, I know you're in that St. Pete, Tampa area, but I didn't realize they called that Central. I always think of that as being towards the north.
Oh no.
We
don't have that southern accent, so we're not North Florida.
I see. That's how you distinguish, is it? Whether people are from that area or not.
If someone has a southern accent, they tell you they're from Florida, they're from North Florida.
Oh, okay. All right. Well, I'm learning. Where were you from originally?
All over really. My dad was in the service, and but we ended up in Orlando. That's where I spent my formative years.
I see. Okay. So let's see. What time is it? It's we've taken our statutory 5 minutes. Hey, Dr. Steve, how are you? Can you hear us yet? Steve, can you hear us yet? No, you can. Well, we'll say hello again in a minute. So we've taken our statutory 5 minutes. We can get started. We have one new gentleman on the phone who I have been corresponding with and is faced with a problem about how to navigate his treatment because he's recently been diagnosed with pretty high risk cancer and is wondering how to go about the treatment path. And Tom Guthrie, and I've encouraged him to attend this call because I've told him we have a lot of wisdom on the call, and so Tom, if you are comfortable and willing to do it, why don't we give you a little bit of time to talk about your situation and give us some background, your age, where you live, the disease demographics, and the problem you're faced with. Is that okay by you?
Sure.
Okay.
Can you hear me okay?
We can hear you well.
Okay. Age 59. I live in upstate New York. My diagnosis was just about a week and a half ago with prostate cancer. The pathology report came back with a 9 Gleason score, so I know that was extremely high. Let's see, my PSA when I started all this was back in the beginning of August, was only 4.4. And I did research into the best ways utilizing a biopsy and found that the MRI for targeting the biopsy seemed to be the best, and so we did have an MRI which did see something. The PIRADs, I think they called it, were 3-4, which weren't terrible, but did show a tumor. And that's what prompted the biopsy, and the biopsy found cancer in 5 out of 13 cores. All were on the left-hand side. None were on the right-hand side. And 2 of the scores were 9, so I guess they go with the highest scores when they utilize that for the Gleason score. Now I've got a meeting with the person who did the biopsy coming up this Friday. He is a urologist / surgeon / oncologist. I don't know if he's an oncologist. He has oncology background. I think his oncology background came from his fellowship, and that's his main focus. I don't think he's an oncologist as well. And he's local, and he's in Albany. And I knew he had some good experience with the biopsy. That's why I chose him. I don't know what his experience is like with robotic surgery for prostate removal, though I know he's going to suggest that. And my hardest part has been navigating the system. It's almost, I found it almost impossible to find out actual numbers for people for experience with robotic surgery, and I still haven't figured out if I'm supposed to be meeting with a medical oncologist prior to the surgeon or a team prior to the surgeon to find out, you know, what the different options are. So those are the things I'm trying to figure out right now. I did use the scorecard that Rick sent me, the surgeon scorecard, but I see that only covers Medicare patients, so that's a limited number of the people that the surgeons see, and it does give some information about their quality level, any issues that they have with patients, but even that has a lot of variables in it, so it's hard to tell, you know, how that really can weigh quality or not. So it's the numbers and the directions, some guidance I've been trying to figure out. I think that's about it, unless anybody has a question.
I just have a couple of questions before I throw it open, because I'm sure there'll be a bunch of guys that want to chip in here. But the first thing is, did the MRI show any involvement elsewhere? And as I recall, you said the bone scan came back negative.
The bone scan came back negative. The CT scan of the pelvic and abdomen came back negative, and the MRI showed no spread in any of the areas. No seminal areas. Nothing. No, not at that point. That's already been almost 2 months.
Right.
Since that time.
And what's your current PSA?
My PSA to start all this was 4.4, but in my general physical just at the end of October, it was 5.5. Came back 5.5. I didn't do any of the things they tell you not to do beforehand in terms of sexual activity the night before or anything. I wasn't even aware I was going to have a PSA that next day. So
okay.
Could be a little high because of that, or maybe it's just rising really fast.
Okay.
I read about velocity, and I know that I had jumped from last year at 2.4 to 4.4 in 1 year, and that was a little too fast regardless of what level it was at. I guess if it's jumped to 5.5, that's really too fast.
Well, I mean, just to give you a frame of reference, I was diagnosed, or my PSA in May in the May before my diagnosis was at 10, and within 6 or 8 weeks it was at 13.6. So, you know, when you've got high-grade prostate cancer, and it very much depends on you individually, because some guys don't have fast-growing PSA, and other guys have very, very fast-growing PSA, but it's not unusual that it goes up at that speed. So the other point that I wanted you to talk a little bit about is the difficulty you've had in communicating with your urologist and your feeling about his feelings about second opinions. Can you just talk a little bit about that?
Sure. He was the person I was referred to by my original urologist, the one who did the initial PSA. He's not a surgeon, but he was my general urologist. So, and I did do some research ahead of time to make sure that he had a good amount of experience. And I talked to NYU about the MRI, because they were the ones that had originally started using it. And in any case, he had good experience, but he just didn't seem to be too crazy about the fact that I had gotten a second opinion on the MRI reading, because it was part of the agency he was part of. That seemed to have gotten him a little irritated, and he also seemed very irritated when I brought a list of things that I had reactions to, medications that I had reactions to, because it was a very long list. I don't know if it was that or he just had a bad day, but he was uncomfortable to talk with. He said something about, when I asked why a month and a half till the biopsy, he said, if it's that kind of cancer, there's nothing you or I can do about it anyway. We didn't think that was a very good remark from a surgeon, but anyway. And his place of business is just very difficult to reach. The last time I called, I was on hold for an hour and a half, just to reach somebody to tell them I wanted to talk to a nurse to ask a question, and of course then they had to call back, which was a couple hours later. So it's not easy to reach them. Everybody's said the same thing to me. Maybe you don't want to work with a person like that, but I don't know. He might have been having a bad day. He was very congenial and nice during the biopsy. He apologized often. So I don't know.
So you're located, when you said to me upstate New York, I guess I figured way upstate, but you're actually in the Albany area, is that right?
I'm in about 20 miles of near Saratoga. About 50 miles from Albany, 20 miles from Saratoga, kind of somewhere in between.
Okay. What's the name of the place you live?
Broad Alban.
Broad, say that again?
Broad Alban.
Broad Alban, A-L-B-A-N?
Yeah, it's near the Sacandaga Lake.
Oh, right. No, because
Adirondack Mountain.
I grew up close to a place called St. Albans in the UK. But,
oh, okay. All right, interesting.
Right. So, okay.
Yeah, I'm not far from Albany.
Okay. So, gents, what are your thoughts for how Tom should go about negotiating his treatment?
This is Steve Rick. I'll speak up a little bit.
Okay.
Just Tom, to give you a little background, myself, I'm a physician, and I have advanced stage prostate cancer. And what you're saying about this fellow, you know, being a little upset by another opinion, hard to reach, those are red flags to me, just by working with him. On the other side of that coin, you know, you're only going to see him until he does a radical prostatectomy, and then probably very little after that. So what you want in a surgeon is somebody with a lot of skill, and the people skills would be nice too, but not necessarily as important. So I would keep that in mind. As far as a very skilled surgeon, I would say, you know, there's no good way in the U.S. of gauging a surgeon's skill There's certainly report cards and so on. I'm a gynecologist by training, so I know quite a lot about this. But I think the best way to kind of get a feel is to ask him how many radical prostatectomies and what kind of robotic surgery has he done and what are his outcomes and so on. My concern is that he may react in a very negative way to those types of questions. So it's a fine. I think that's the best way to get a feel. If he says, well, I do 3 radical prostatectomies a year, that would be a red flag, right?
Right, right. And I think I found him on the site. He didn't have, under the report card, he didn't have enough to rate him on there, but that again was just the Medicare folks. So I am going to ask him that question. I don't know if he'll answer it. He didn't answer the question when I asked about the number of biopsies. He said many, and when I pushed it, that's all I got was many. So it doesn't matter. In this case, I'll push it till he answers or I can't get it. But Steve, is there a way to ask that question of the hospitals? Can I contact the hospital and say,
actually,
yeah,
there is. You could actually get that information, but he might perceive that as going behind his back if he isn't ready to volunteer that information. So I do think asking him up front, saying, how many of these do you do? How successful are your outcomes? What sort of complications have you had in the last year? I think those are important questions when you're going to put yourself in the hands of a surgeon for a pretty significant operation that potentially has a lot of side effects.
Yeah.
The only other comment I might make is, it certainly doesn't hurt to see a radiation oncologist and perhaps a medical oncologist as well before you make any real decisions here. I mean, you got confined to the prostate, Gleason 9, but still is confined to the prostate. So it may sound to you like this is horrible, but it's certainly not as bad as a lot of people probably on this chat room have. That's for sure.
Yeah, I guess my biggest worry is that I take too long trying to find this information out and searching for the right person. That it's confined now as far as we know, but who knows when it's not going to be confined? I guess that's
right.
I don't know. I guess I'm rushing because of that.
Yeah, it's a tough situation. I would be very upfront with the surgeon though and say, tell them that you participate in a support group, and one of the things, there's a physician on there and among many other very experienced people, and one of the things they said is they'd like to know your history in terms of how many of this type of surgery do you do, how active are you, and do you have some complications recently? And as a surgeon, when patients would ask me that, I would absolutely volunteer it. It's absolutely fine with that. That's something I would expect a patient to want to know,
Right. All right, thanks. Yeah, I thought so too. And I don't mind asking. I mean, maybe he was having a bad day. Anything's possible.
Right. So, Tom, one thing I do want to say to you, I think I mentioned it in the email, is that, and I can only speak from my own experience, and we certainly don't give medical advice here, but this may help you a little bit, is that I got diagnosed in I had a high PSA in the May, and I had a biopsy in August, and my biopsy came back with 4+4. I think I had, I can't remember, 7 cores out of 14 were positive, and 2 or 3 of them were 4+4. And my doc said to me, and he's a really good doc, and I still see him, that he was comfortable if I took 4 months, 3 to 4 months at most to make a decision. He said, as long as you make a decision by the end of the year, I think you're fine, but you've got to do something by the end of the year. Now, the other thing to bear in mind is that if you felt like you needed more time, what some people do, and it's a possibility, is they get a hormone shot, just one hormone shot, which might be a 3-month hormone shot, which can make the cancer pretty dormant, especially if it is not, it doesn't appear to have gone too far, and that gives you enough time. I mean, my own thinking is that given that you have a Gleason 9, most doctors are willing to see prostate cancer patients with a Gleason 9 pretty quickly, and they'll fit you in. And as long as you make it known that you have a Gleason 9, if you want to get a second opinion from anybody, then you can make that work. Now, where you are, you're probably about equidistant between Boston and New York City. Is that reasonable to assume?
Yeah, they're both about 3 hours.
So, you know, I feel that with high-risk prostate cancer, which is more likely to involve future treatment, that you're better off at an institution of excellence, which for you would probably mean either Dana-Farber or Memorial Sloan Kettering. And I think in either place you could probably work it out that you could see a radiation oncologist and a urologist in the same visit, and maybe even a medical oncologist, or, you know, subsequently you could go back after you've digested what they tell you and discuss it with a medical oncologist. But all all three disciplines are available to you in the same hospital if you go to an institution of excellence, and none of them have an axe to grind in the sense that there's no financial conflict of interest for any of them. They're all salaried, and some of them are probably research docs too, and so they're not going to be pushing you to do a treatment because they're going to earn anything out of it. That doesn't mean to say that they don't have a bias towards what they do. Here at UCSF, if you see somebody like Peter Carroll, who's the head of the department, he's usually very reasonable, and he weighs things up. He doesn't push you into surgery. At the same time, you see people that are the head of the department or very senior in the radiation oncologists, and they tend to push you towards radiation. But as long as you know that going in, that they're going to show a bias, you can factor that in. But you know that they're not pushing you into a treatment because they're going to be earning out of you, and I think that's an important factor. Who else would like to? I mean, there's some other people on this call who've been faced with similar situations. Who else would like to contribute?
This is Jake. Hi, Tom. Sorry to hear. Sorry to hear you're in the same boat as the rest of us.
Yeah.
I definitely agree with Rick and Dr. Steve. They both give you good advice. The things you said about your urologist, so kind of concerns me. I would not be too concerned about that, the waiting period, because they do get busy, and as long as they call you back within, you know, a day or so, you're probably going to be, probably can't expect much more than that. But the thing that concerns me, it doesn't sound like he gave you any other options. You know, my urologist, when I found out I had it, he said, well, we could look at, you know, he gave me all the options that were possible, not pushing one or the other. And I would be a little bit concerned about a doctor that does not do that for you.
I might have given the wrong impression then, Jay. Just to keep the record straight, I haven't even met with him yet. My biopsy results came back two and a half weeks ago, and the only reason I know what they are is because he called and told me. I'm not meeting with him until this coming Friday.
Oh, okay.
So I haven't met with him to talk about other options. I have no idea what he's going to present, but he did say on the phone, these are your results, and I would take it out. In fact, he said I would take it out, and then I'd get some additional treatment after that. That's all I got from a phone call. It wasn't a good spot to try and discuss things. I figured we had an appointment coming up, so that was it. So I can't say he won't go over some other options.
Well, and one other suggestion I would make is, and I don't want to scare you, but when you do go to him, I think you want to ask about a term called micrometastases.
Okay.
Rick and Dr. Steve can weigh in on that, but that's basically it's too small. It's cancer that's too small to see on a scan, but that can spread, and that's probably why hormone treatment might be a very good option for you, I would think. You know, they thought they got all of mine, because I had Gleason 8, and they thought they got all of mine, and they did not. but they didn't. It was not visible on any scans. So I would just ask the question about it and what the possibilities are and what the potential treatments are for that.
Okay, thanks. I appreciate it, guys. Are there reactions to the hormone therapy too? Because it sounds like that's like almost sounds like an automatic that people should get that while they're waiting to make the decision, or is there something that their reaction that they don't want to have people run through?
Well, I think Rick made a good suggestion. You know, chances are, you know, especially if you're not going to do it right away, it might not be a bad idea to get one just to kind of keep things at bay, more or less. The hormone shot itself is everybody responds to it differently. I never had much issue with it. Some people, you know, don't, you know, feel bad on it, but I did not. I don't know. It's a personal call, but your doctor should discuss those things with you.
Okay.
And if he doesn't mention all those things, then maybe you should find another doctor. Is my bottom line suggestion.
Jeff Ledoux, you're with us, correct? Jeff,
I am.
you are.
I
Good.
am.
And you know, this although it isn't the same situation as you, there is some, you know, I'm reminded of what you went through to find the right doctor in the first place.
Oh, yes. When I was initially diagnosed, I got no information. I was put on a treatment of ADT plus chemo, and I didn't get any information for 9 months.
I can't hear him.
At that point, I almost jumped ship. But back here in June, when I was, my BSA was starting to rise again, I was put on Casodex, and I asked, what about side effects? Oh, look it up on the internet, the doc told me. Okay, well, I did. And I showed up with a side effect. I said, what do I do about this? His nurse called me back and said, well, Mike said, call your PCP. At which point I jumped ship. I have found a group that has listened, has done things that we agreed that should have been done sooner, but they've been done now. I'm headed for my 3rd infusion of Provenge on Friday, and basically whatever I want to do to fight this thing, he has agreed with and continues to do so. So I'm very pleased with the decision that I made to find another physician to work with.
So, Tom, I want to say that, you know, there are drugs and names getting thrown around which you're not necessarily going to understand because they are more involved with advanced treatment. But the point that I want to make and that I think Jeff was making is that you should not be intimidated by your doctor. You have to advocate for yourself. And there are some concerns that I would have with your urologist up front. You know, one of which is the difficulty. I mean, leaving any patient on hold for an hour and a half is questionable to me. And then waiting so long to give you an appointment when you come back with a Gleason 9 biopsy, it just isn't right. Most urologists that I've encountered will give priority to people that have high-risk disease, if for no other reason, not so much because the disease is likely to spread very quickly, because that's not usually the nature of prostate cancer, although it can happen, but more that just to give you a peace of mind. At the same time, I can also understand that he wants to see all of your tests back, and you only just got your bone scan back yesterday. So, you know, that's in his defense. But there is a concern to me. The other thing that I want to raise, and maybe some guys will talk about it, is that this nomogram that you and I have talked about would be very important to me personally if I had your situation, because the treatments that you're facing are, the treatment choices that you're facing are some combination of surgery, radiation, and hormone therapy. Now, maybe that you don't need anything more than surgery, but if you run the nomogram, it's going to tell you how likely that situation is based on a whole number of people at Memorial Sloan Kettering who had very similar disease demographics to what you have.
Right.
Now, that doesn't mean it's going to be the same for you, but it's a comparison of what might happen in your case based on what happened to other people that had similar situation. Now, if that suggests that surgery alone is not going to be sufficient, which is really what the urologist is telling you up front, you then have to make a decision. Well, if I'm going to be doing some type of radiation and I'm going to be doing hormone therapy, is there enough benefit for me to do surgery as well? There's no question that there is some added benefit, but nobody can really say how much that added benefit is. I spent a lot of time researching that. There were no papers, and I still don't think there are any papers. The best estimate that I got was from Peter Carroll, who I mentioned earlier, who in his mind said, well, in my view of everybody I've seen, it's maybe makes a 3 to 4% difference. So I then had said to myself, well, do I want to do surgery on top of radiation and hormone therapy? And I decided not to. Some people might say, I want to do the surgery. I mean, if you're fit and you're healthy, you should be able to deal with it pretty quickly. So these are just some considerations on why I'm encouraging you to run the nomogram, so that you can have all the information available to you. I mean, if you walk into your doctor on Friday, and let's just say the nomogram shows that there's a 70% chance that you're going to need hormone therapy and radiation, then my question to your doctor would be, well, what difference is the surgery going to make? If I'm going to do hormone therapy and radiation anyway, what difference is the surgery going to make? And see how he answers that.
That may, speaking to the surgeon and saying that, the difference is pretty apparent, that puts him sort of in a situation where he's not necessary. My own experience, I ended up, I was too far advanced to have surgery, so I had stereotactic radiation as well as external beam radiation to one spot, and as well as I've been on ADT, on hormones basically, for a little over a year. I think the whole treatment of prostate cancer is shifting very dramatically, and urologists are increasingly kind of left out of the loop. As you get to the CyberKnife and the Varian and some of the stereotactic types of radiation that are currently done, they clearly are more benign than a radical prostatectomy. So I really would keep an open mind about that. That's why I suggested maybe seeing a radiation oncologist at a big institution like Memorial Sloan Kettering, or somewhere close enough where it's not arduous to get there, at least for another opinion. I think it's a very good idea. I would not simply see a urologist because, the expression, to a hammer, everything looks like a nail, right? I think to a urologist, everything looks like a radical prostatectomy.
Right.
Well, I on the one hand, I certainly agree with you, Steve. On the other hand, it may well be that surgery is redundant, or if it's not redundant, it only adds a little bit. of benefit, and it does involve a bunch more comorbidities, side effects. And I think a good urologist is going to say, look, this is what you have to weigh up. I mean, you know, a Peter Carroll is going to say, yeah, it's going to help you. There's going to be a benefit, but the benefit is not huge, and the side effects could be significant. And, you know, I would hope that the urologist that I saw was pretty honest about that. I mean, my guy, I was treated at both Kaiser and at UCSF. Kaiser is a very large health maintenance organization that is renowned for employing Steve Bornstein for 35 years.
That's not a solo claim to fame.
But I do. I mean, I agree with Steve, and you know, it does to some extent make it sound to the urologist that he may not be essential to your treatment, but maybe there's a good argument why he thinks that the surgery is important, and that's what you need to be hearing.
So I'm getting the impression that let me tell you what I was thinking of doing tomorrow, as I've been gathering all this information and trying to understand it. I thought tomorrow I would try to contact a couple of the places where there were teams, where there would be more than one person to talk to, where there would be a medical oncologist and radiologist there along with the surgeons, and I would first find out, if I could, if it was feasible from the hospitals, if there were certain levels of experience with the surgeons in those sites, because I kind of figured if I ended up going to a place for the team, I wouldn't ignore the surgeon if the surgery was the part that needed to be done. And it seems to me, from the things that I've read, that experience is an important part of the radical prostate removal. So, and I'd hate to go someplace, find out I had a really good team, decide that surgery was an important part of it, and then find out the surgeon had done 300 of them instead of at least 1,000, like the information I've read from the cancer symposiums. So does that sound like a way to go? And Dr. Steve, you said it was feasible to garner that information. If it is, where do I start when I contact one of the sites?
Well, I think in terms of just the numbers, you should just ask the urologist. I mean, that's the simplest way. And if they say, I can't tell you that information, I would ask them why. And if you can I won't have any contact with a urologist at that point. Say I contacted Sloan Kettering tomorrow. I don't know anybody there. So where would I start to find out that type of information? Well, they'll hook. I think a place like Memorial Sloan Kettering can hook you up with, you know, these are the urology choices, and this is their experience, and so on. I think, generally speaking, there's a department called Health Information Management that collects that kind of data, and you're entitled, if you're seeing that doctor, to look at that. So it's doable, but again, I think the easiest and least adversarial way is to just go to the doctor and say, you know, what's your experience with this? How many have you done? How long have you been doing them?
Right. Well, let me just add to that. I mean, if you're going to call MSKCC tomorrow and say Dana-Farber, just for argument's sake, just to make a comparison between the two, you probably want to start with making a call to urology and make sure that you tell them up front that you're a Gleason 9. You're 4+5, right? Not 5+4?
No, I'm 5+4.
Oh, you're 5+4. So make sure you tell them up front that you're 5+4 in 3 cores, that you really want to get a more comprehensive view, and you would like to make appointments to see, at least initially, a radiation oncologist and a urologist. Now we can give you some names at Memorial Sloan Kettering for sure. Len said he wasn't going to make it on. Are there any? There's no one else on here right now from Memorial Sloan Kettering, is there? No. I can send you a couple of names of surgeons at Memorial Sloan Kettering. I don't have them off the top. I don't have them off the top of my head, and I can send you definitely a couple of names of radiation oncologists. The guy who runs the department is Zalewski, is very good, and the guy that our friend Lenciera has just seen, he likes very much, and he finds him very easy to talk to. Boris, I can't remember his last name, but I'll send you the name. I'll send you the name when we hang up. And then in terms of surgeons, I'm just blanking, but there are a couple of surgeons that we know are there. Scardino, I think, is the guy that runs the department. I don't know. He may be an older guy, so he may not do robotic, but I've got names of surgeons. So, you know,
I've got Torger and Laudon were listed on the scorecard.
I don't know. How do you spell the last one?
Laudone, Vincent Laudon.
Laudon, yeah, I do know. I have heard of him. We have had guys, I've worked with guys who have seen him, Laudon. But let me look, and I'll send you a couple of names. But I think I would probably suggest that you make you ask for an appointment with this guy Boris. Let me look and see if I can find his. I can find his last name.
That's all right. You don't have to find it now. I feel like I'm taking up people's time.
So I'll
looking there. His suggestion about getting like a Lupron shot, make sure they do some sort of peripheral blockade with KZX or something before. But I think that's an excellent suggestion. I think you should, you know, it will, you know, appease the waiting period here for you so that you're not so worried about it, and it will actually shrink down the tumor mass enough where it makes the surgery perhaps a little easier. So I think that's an excellent idea. I would jump on that one right away.
Yeah, I mean,
make sure they do what beforehand?
Consider Lupron. Consider a hormone therapy shot.
But he said something
and before
about
that, yes. Well, it really depends what they're going to give you. If they give you a drug called Firmagon, then you don't have to worry about doing anything beforehand. If they give you any other drug as a hormone shot, then just make sure that you take they prescribe another drug. The generic name is bicalutamide, bicalutamide, bicalutamide. And make sure you take you get the bicalutamide for at least 21 days before you have your 15 to 21 days before you have your shot. But if you go to a center of excellence, it shouldn't be an issue. I'm not saying it won't be an issue, but it shouldn't be an issue.
Okay. What was the reason for this bicalutamide before
the reason is because of the way the hormone shots act. The other drug you're going to get acts, which is called an LHRH drug. It can either, I don't want to get too complicated now, and we can talk and I can explain it to you, but in certain ways, there are certain ways in which it works that may cause your testosterone to rise before it falls. And that could be a problem if you have any hidden metastases anywhere. So this other drug is just a buffer.
You know, my experience was actually I ended up with acute urinary obstruction. I took the KZX bicalutamide about a week, and then I started on one of the anti-androgens, Lupron, and I ended up in the emergency department needing a catheter. So it's just something, they'll know that at any center of excellence, but you just want to make sure. And I do think, personally, with Gleason 9, anticipating any kind of treatment, you're probably going to end up being on hormone therapy anyway because of what somebody was talking about, micrometastases and so on earlier. So I think that it just makes good sense. And so I would preempt, since you're waiting here to get some opinions, I would preempt that and just get going on it.
So, you know, this is definitely something to radiologist, the radiation oncologist's last name is Muller, Mueller. And I think what I would do is I would probably, if it were me, I would call Memorial Sloan Kettering, tell them I'm a Gleason 9 5+4. I would like an appointment with Dr. Muller, and I'd also like to see an oncologist. And is it possible to do it on the same day because I'm coming from out of town? It may restrict which oncologist, which urologist you did I say oncologist? I meant to say urologist. That you want to see the radiation oncologist and you want to see a urologist on the same day. It may restrict your urology choice, but I'll give you a couple of names there and you can run them past me when they offer you and we can see. But I really, you know, from what the way Len has spoken about Boris and the fact that Len came to Boris through another very dear friend of ours and of mine who passed away last year, who also spoke very, very highly of him. I think he might be a really good guy to sort of settle you down and give you some guidance. And if he's the sort of guy, I think, that if he thinks surgery is a good idea, he's going to tell you surgery is a good idea. Anyway, look, we've, like you say, we always take a good bit of time with somebody who's new, and you know, every one of us on this call knows what you're going through right now when you first get diagnosed and how difficult it is to navigate. Tom, we are definitely around for you, and I will connect you to somebody who's actually seeing or saw Boris. I'll connect you to Len. He's not on the call today because he went with another one of our guys to attend an appointment with him. So he was feeling pretty worn out. But come back on the call. Our next call will be on Monday at 8 o'clock your time. You feel free to give us an update and feel free to reach out to me in the interim, and we'll do some help and do some connecting. And you know, we've got your back here. I think that's probably the best way to put it. I hope that by connecting you into this group, you're not going to make a bad decision.
Okay.
Richard.
Well, thank you, folks.
Yeah.
Richard,
Yeah.
I want to throw one thing out there that I just found out about probably just a couple of months ago. There's a clinical trial somewhere, and offhand I don't remember where it is, but it could easily be researched. They're finding that Casodex leaves a lot to be desired. It does the job, but a lot of side effects and this and that. And that abiraterone is better, you know. And it used to be that you couldn't get abiraterone until you had chemo. They got a clinical trial now using abiraterone before Casodex.
Mm-hmm.
And it's just something this guy, I didn't hear his whole story, I just got on, but he may want to look into that clinical trial.
Well, this is a little different, Tom. This is a gentleman who just got diagnosed, and we were just talking to him about using bicalutamide Casodex as a buffer, and not as a hormone therapy. You know that when you start using Lupron, for example, you should take 10 days or 15 days of Casodex before you.
But not to stay on it.
That's right, not to stay on it. But thanks, and we need to hear a little bit more about the impact of Casodex. So let me just do a quick check-in as to who else is on the call. And this is who I know, and I think there's at least one person that I don't know. So I know that we have right now Steve Bornstein, Bill Franklin, Eric Bookbinder, Dennis Correa, Jake Hannum, Jeff Ledoux, Paul Hobson, Tom Guthrie, Ron Shaheen, Tom Van Zandt. Anybody I've missed?
Ron and Susan from Delaware.
Ron and Susan, welcome home.
Thank you. It's a beautiful place.
And I've got somebody on the telephone that I don't know who it is. If you don't want to identify, that's fine. But I got one other person. Well, I'm going to go down the list, and if I didn't call your name and see if there's anything you want to talk about, you can tell me when I get to the end of the list. Steve, anything for you? No?
No, I'm good, thank you.
Okay. Bill Franklin, how about for you?
I'm good, thanks.
Okay. Eric, bookbinder, anything for you, sir?
No, not right now.
No? Okay. Dennis Correa, how about yourself?
No, I'm doing good.
Okay. Jake, how about you?
Just a brief comment.
Okay.
I'm glad to see your recording. I forgot to tell you.
You intimidate me. As soon as I see your name, I check to see if I'm recording.
At 10 minutes to 7, I realized, I better tell him to record, and I saw you already were.
There you go.
My goodness.
Jeff Ledoux, anything for you? You can give us an update. We haven't heard from you for a while.
One quick question,
Okay.
and I can give you a little bit of an update.
Okay, we'll come back to you. Paul Hobson, are you still listening in?
Yes, still listening in.
Okay, so we want to check in and see what's going on with you since you're indisposed in a medical environment. So we'll check in with you.
Okay.
Ron Shaheen, how about you?
Everything's just fine, Richard.
Yep. Do you need
Okay.
Do you need time?
Nope.
No? Okay. Tom Van Zandt, how about yourself?
No, I'm holding my own here.
Okay. And Ron and Susan, if nothing else, I'm going to give you some time. You can at least tell us what you've been doing for the last month. So I'm putting you...
I do have some questions in regards to the prostate cancer also.
Oh, okay, well that too. We can handle that too.
Yeah.
Now, have I missed anybody? Anyone else? Okay. All right. And if you could mute if you're not talking, that would help us. Okay, so let's start with Jake. Jake, you're up.
Okay, I just wanted to comment. I did based on your suggestion about stopping the Casodex. My PSA had gone up with 2 points in 1 month, so you and Lynn and a couple other people suggested, stopping it. So I contacted my oncologist. She wasn't real thrilled with the idea, but she said yes. So I stopped. So I took my last one on Sunday night. It'll probably take about 6 weeks to see if it has any effect on my PSA.
Mm-hmm.
Based on my reading, I found that the anti-androgen syndrome that they talk about, it only benefits about 20 to 30% of the people.
Yep.
So I hope I'm one of those.
Yep. I mean, why was she reluctant? Because of a small percentage, or?
I didn't actually talk to her. I sent her an email. She's another one that's hard to get in touch with, But I think she just wanted to go on a little bit longer. She's the one. She likes to go to PSA of 10 for everything, and I think she would have liked to stay with the bicalutamide a little bit longer. But she said she'll go along with what I suggested.
Okay.
I told her why, and she said okay.
And where's your PSA right now?
As of October 22nd, it was 5.5.
Okay.
They'd gone up 2 whole points since October.
Right. I mean, the thing is that your PSA never moves that. I mean, it's not. You don't make a huge amount of PSA, and you have to. She should be figuring that in when she thinks about your case. I mean, 10 might be right for somebody that's sort of normal, but if we look at your PSA history, it doesn't swing around a lot.
Well, it got down to 0.5 at one point on Lupron, and then gradually it stayed that way for about a year, and then it started gradually rising. And this is the first time it ever went up 2 points in a month, though.
And what's the highest it's ever been?
On treatment, it's only been up to about 7. Before treatment, it was up to 23. When I actually went to the oncologist, it had gone up to 23.
Mm-hmm. Mm-hmm.
But since Lupron it's never gone above 7.5, I believe.
Okay.
Don't hold me to that. I don't have the exact number.
That's okay. That's okay. That's okay. Well, look, you're absolutely right that, you know, it doesn't work with everybody, but it works with probably, as you say, 20 to 30%. If you're in that group, it's good. If you're not in that group, you've got to move on, and you probably got to move on anyway. So,
Right.
What's
exactly.
the downside, you know? Anybody else want to talk about? I mean, you heard what Tom Van Zandt said a little earlier about the fact that maybe Casodex is not as efficient as it might be, and it's always been considered, abiraterone has always been considered an alternative to ketoconazole. It's probably surpassed ketoconazole now as the drug of choice, but they work in sort of similar ways. But anybody else want to talk about Casodex, stopping Casodex? Anybody had any experience stopping Casodex? Eric.
Yeah, this is Eric. So, you know, I had a similar thing happen, and my PSA started going way up. And the doctor switched me to enzalutamide. But in the meantime, within weeks of stopping the Casodex, my PSA went way, way down. I went down to almost nothing.
Mm-hmm.
And so I stopped the enzalutamide. Again, as just like you, not my oncologist didn't want me to, but you know, I had the PSA gone way down, and I didn't want side effects. Within a month, it was already on its way back up, and so after 2 months, I started the enzalutamide, and I was on that for, I don't know, 9 months, something like that. And PSA started going up again, so now I'm on experimental drugs.
Mm-hmm.
But my PSA, the highest it's ever been is right now. It was well, the one test said it was 8.5, and the other one said it was 7. So
Mm-hmm.
that's the highest I've ever been, and that's, you know, now after doing all the other things.
Mm-hmm.
But I also did the chemo right after I started the Lupron, based on the chartered study from England. I don't know if it helped or not, but I'm still here.
Mm-hmm. Look, I just want to say one thing, Tom. You're probably still listening in, and I really don't want you to be scared out of your wits from what you're hearing right now. And I mean, it is a bit of an issue for me. I mean, we set these calls up for exactly for people like yourself, as well as people with recurrent and advanced cancer, because people with high-risk diagnosis oftentimes don't get good advice. And so, as you heard, you can get some great advice here. But if you feel that you don't, you know, you don't want necessarily, you don't need to hear what we're going through now, feel free to leave at any time, and I'll drop you a line later on. But most of these gentlemen have done chemo and a lot of drugs at different points in time, which is what happens. This disease can be managed for many years, which is the good news. The bad news is that if it comes back, it stays with you. So, anybody else want to talk? I mean, well, Jake, there you go. There's a good example. You know, yes, you may get some benefit. If you get some benefit, it's only going to be for a few months. But in the spirit of what your oncologist likes to do, which is to get the most out of every single drug, getting the most out of Casodex also includes going off Casodex.
Right. Well, after you and Len suggested it, I did some more research, and I definitely agree with you that it's the way to go. It seems to be the standard. So
right.
We'll see.
Okay.
I understand it takes about 6 weeks before the Casodex to get out of your system.
Mm-hmm.
That
Mm-hmm.
for any any indication on your PSA of how it responds,
Mm-hmm.
and hopefully I'll be like Eric and respond quickly. and hopefully longer.
Okay. Jeff Ledoux.
Good evening.
Good evening.
First thing is,
are you freezing your nuts off in Maine right now?
temperatures are in the 30s. Let me see. Right now, 33 degrees, 39 degrees, somewhere in that vicinity.
Okay.
So, I don't have any freeze off anymore.
Okay.
You know what I'm saying. Anyway.
Am I the only one having a problem hearing Jeff?
No,
So what?
no, we're all, I think it's your internet connection is probably not as strong as it could be. It's probably going in and out. So I think we're just going to have to bear with it and try and pick up what we can from you, Jeff.
All right. The update is that I've just had my third leukapheresis.
Okay.
So that'll be on Friday. I'll get the third shot of Provenge. So that's good news.
Okay.
My one question is, and it has to do with the notes that I've been getting from my doctor. Under prognosis, it says guarded. You know, that almost makes me want to lie down, curl up in fetal position, and go ahead and die. But I don't feel that way. What are they saying to me?
Dr. Steve, this one falls right in your sweet spot.
So they say the prognosis is guarded. Is that what they said, the term?
That's what they said.
Yeah, I don't know what that really means. You know, I think it's such an unpredictable disease. I think, you know, if you look at the raw data, Provenge, you know, and the same with Xofigo and enzalutamide, a lot of these drugs, you know, they prolong people's lives by, on the average, 3 months, 3 to 4 months. And so the data would suggest, statistical data would suggest they don't prolong your life for that long. And unimpressive, whereas the Charted study that Eric was talking about really was much more impressive, using chemotherapeutic like docetaxel with ADT initially. So, you know, I guess what they're talking about is that if you look at statistically, the median person is going to die within, you know, 12 months. Maybe they're calling that guarded. Hopefully you and I and the rest of us are not that median person, and we're the guys that are going to stay around a little longer than that. And I think that's highly dependent on your general health and your age and a lot of other factors. So that's, I think they're just going by statistics, and guarded meaning that you probably, you know, statistically don't have long to live, statistically.
Okay. The other part of that is that when I did the study on the Provenge, they say 38%, I think it's 38, might be 31, are still alive 3 years out after having the Provenge. I'd like to be part of that 31%.
Absolutely, absolutely.
So,
you know, that's where you want to be.
So you have to recognize that many times when these drugs are placed in clinical trial, especially these new drugs, they're given to people with very advanced cancer to see if they make a difference. They're not given to people necessarily earlier in the disease stage, because they're looking for the magic pill, and they want to see if this drug is the magic pill. So when they say 4 months, 5 months difference, you really have to go back to the study, and you've got to look at how sick were the people that got the drug in the first place. And many times you're going to find that they were a lot sicker than many of you are who have gotten the Provenge. And what we do know is that the earlier you get the Provenge, the earlier in the disease cycle that you get the Provenge, the better off you're going to be. And I've talked about this. I mean, the principal investigator for Provenge is a doctor that I am probably, you know, of all the prostate cancer docs of all the different flavors, I'm probably as close to him as any of them. And we've talked about this because we've also talked about how useful is Provenge for people with more advanced disease. And as he says, the more advanced your disease, the shorter is the landing strip for the Provenge to work. It doesn't mean to say it won't work, and it doesn't mean to say you shouldn't get it. But you know, with this came up with my friend Trevor, who was pretty sick and never responded to anything. And should he have gotten Provenge or not? And I called Larry about it, and he felt that, you know, probably wouldn't help a huge amount. Probably wouldn't hurt, but wouldn't help a huge amount. Now, if you gave Trevor Provenge, that's the sort of space where maybe it would have made 1 to 3 month difference. But giving Provenge to somebody like yourself could have a heck of a lot more impact. The fact that your outlook is guarded is because you have metastasized cancer, and metastasized cancer provides a guarded outlook. Could you live with it for a long period of time? I think you could. We see people that have. At the same time, you know, you've got to be watchful, and you've got to be on top of your disease.
The other thing, Rick and others, you know, the statistics look at median overall survival.
Exactly. Yeah.
We'll call it OS, median overall. A lot of the people, if you look at the average age, it can be 75, 77, pretty advanced age, and many of these people die of other diseases. If you look at cancer-specific death rates, it's a very different thing. And with Provenge, interestingly, if you look at the stat, I'm thinking of taking it right now. I've been throwing everything. I'm on radium right now, and I think I'm going to take a break on the radium and go with Provenge after this. But statistically, those people with less tumor burden, and that does correlate with how advanced the disease is, and they define the tumor burden by PSA. And that can be accurate or not, because as you well know, some cancers don't produce as much PSA. But at a PSA level of 22 or less, there was a much higher incidence of a enduring response. Between 22 and 50, the response was less, and a PSA between 50 and 100, the response again was much less. So it really seems to depend with Provenge specifically on the tumor burden, and you want to hit yourself with it when the PSA is at least 22 or less. So
right.
That seems to be key.
Right. That's a very, very good point, Steve. Mind you, you know, Steve measures each treatment by how it affects his tennis game. So he's still looking for the right drug to improve his tennis game.
The radium is screwing up my serve, and I'm going to stop it. You know? I got my priorities, you know.
Okay, I've got 2 other quick points. One,
benign for me so far. 3 doses.
Go ahead, Jeff.
The first point is that my bone scan that I had done in September came back with reduced, improved.
Good.
So I was real happy with that, and then I get this guarded prognosis. Wait a minute, if things are improving, my PSA, as you mentioned, is 1.28, which is well below 22, and done the Provenge now. Hey, it's going to be a month or 2 before we know anything about how that has reacted, but I'm overall real pleased with the direction things are going.
I would look at that guarded prognosis and just throw it in the garbage can. It means
Thank you.
That sounds like it was some careless talk. And if anything, if it really worries you, I would ask for more of an explanation from them on that, if you can't get it out of your head. But I think I'll just ignore it and monitor your situation.
I plan to do that Friday.
That's
good.
good.
If you have an appointment coming up and it's bothering you, I would want a detailed explanation.
Yeah. And the other thing I'd like to suggest is, I mean, this is a really good topic of conversation for John Teisberg's Inner Conversations meeting. You know, the one that he runs, I think it's on 2nd and 4th, Thursdays. if he remembers to show up, right, Jake?
Yep.
I'm sitting at my computer on Thursday night and I get this urgent email from Jake. Do you think John spaced out the meeting? And he'd sent out a meeting reminder, so I sent him a text and he was busy munching Kentucky Fried Chicken and completely forgotten that he was supposed to be moderating a meeting. Whoops, he said to me, I'll be there in 20 minutes. And we did get him in, and it turned out it was a very good meeting. I don't usually attend those meetings, but Jake may well be lined up for a bigger role in those meetings. And Jake, don't you think that this sort of what does guarded mean is a good topic for that in the conversation?
I'm not so sure about that.
No? Okay.
I think guarded to me is more of a medical terminology. The meeting we're talking about, Rick, is more like feelings and how do you respond to this and how do you respond to that. It's specifically not technical.
Richard?
Usually all, critical, guarded, etc. are hospitalization-related terms. They don't really use that for outpatients.
Got you.
So I think they're confusing it with somebody's admitted to the hospital and their prognosis is guarded. That would be, or critical, or serious. They're hospitalization terms. I've never seen them used in relation to an outpatient like that. So I think it may be a little confused.
I'm going to come to Ron right now, Ron Sheen, but I just want to say one thing. I mean, the reason why I see it as being a good topic is because it isn't really what it means, it's how you respond to it that is the issue here.
Right.
And emotionally, it's giving Jeff an issue, a problem, and it doesn't really matter what it exactly means. Jeff is feeling good. His disease is seems to be under control, and then they say guarded, and it throws him for a loop. And that's the sort of thing that I feel is a good thing that gets discussed, the sort of thing that gets discussed on that call more than it does on this call. Ron, go ahead.
Good point.
Well, my feeling is that if you have advanced prostate cancer, you know that you're not going to be cured. And so everything that we do as far as treatments are concerned, we're looking for positive results. We're looking for delay, we're looking for PSA to go down, we're looking for bone scans to be improved, no new sites. We're looking at those kind of things. So I think your quality of life and how you feel every day is probably as much as important as anything else. And those times that your PSA doesn't go up from some particular treatment and goes down for a couple of months, that's discouraging, but it's a reality of the disease, And I think as we live longer through this situation, you have to keep that positive mental attitude. And every day, every week, every month is a great thing that we have. I just completed my 12th chemotherapy session yesterday, 1 year on chemo, and I'm feeling pretty damn good. Every month, basically for the last 7 months, my PSA has gone down 100 points. So I would be tickled when my PSA goes below 100. And I remember not too many years ago when it was at 3 and it went up to 3.2 and I was scared shitless, So I just think that when you get something like guarded or some prognosis like that and you're still feeling well and you just found out that your bone scan was more positive, you've just got to keep that attitude.
Right. I think that's good advice. By the way, what is your PSA right now, Ron?
My PSA as of Sunday was 148.
Okay.
And when I started this, it was 803.
That's right. I remember.
Yeah. Ron, I wanted to give you congratulations. You kept your hair through your chemo.
Yeah, my hair is surprisingly come back. you know, everybody says when you stop the chemo, your hair will come back. Well, I lost all my hair after my third or fourth treatment, and it started growing back after about my sixth or seventh. So I don't know.
Yeah.
I take it.
Those
you know.
chemo in the future, giving us hope.
Yeah.
Ron, you got a nice beard also. I can't grow a beard like Rich.
Yeah. Well, the interesting thing, Steve, is this is the only place where I'm here, and it's the only place anybody can see. So I guess that's okay. So I don't know how that works, but.
Well, you're looking good, and that's important. You're looking a lot better than you did when you started on the chemo. And,
that's for sure.
You know, I think again, everybody makes different amounts of PSA. How are those recent bone scans? Are they showing any change?
No, it's a good question. I have my next bone scan tomorrow, so
okay.
The next time we get. Yeah, so the next time we get together, I will let you know.
Okay.
Ron, which chemo are you on?
I'm sorry?
Ron, which chemo are you on?
I am on Jeftana, and I started on Taxotere. I was on Taxotere for 4 sessions, and my PSA continued to go up every session. And as soon as I switched to Jeftana, my PSA started going down. It went down actually after the first treatment. It went down about 103, 105 points.
Oh, Ron, how did you, between Taxotere and Jeftana, side effects wise, do you feel one's better, worse, the same?
You know, that's a good question, Stephen. And I quite frankly, I've never had severe side effects from chemo. I lost my hair. I've got some constipation at times. I've got numbness at the bottom of my feet. I had some tingling in my fingers. My oncologist put me on vitamin B12. That stopped the tingling in my fingers. I've never had any really upset stomach or, you know, nothing that I ever would say, gee, I better stop this stuff. My biggest concern right now, and I'm going to have a meeting on the 25th with my oncologist, is my biggest concern is being on this poison for a year. It's very effective for my prostate cancer, but what the hell is it doing to the rest of my body, you know? My quality of life is good. I got some trips planned for next year. You know, he's not a guy who thinks that I should stop and take a vacation. He's very conservative. He does feel instead of going 3 weeks, I can go 5 weeks in between or something like that. But he says if I was concerned, we could reduce the dosage. And I'm on the max dosage now. My curiosity is how low can I go with my PSA? So I probably would not want to stop the, you know, reduce the dosage until I really saw the PSA kind of like peak. That's my I don't have any medical backing for that. I've done all kinds of trying to Google research on how long people have been on chemo. You know, I guess we have a guy that's here in our group that's been on for 5 years, and that's all in Australia or someplace. Mm-hmm. I know people have been on for 15, 18 sessions, so I don't know.
I'm surprised to hear that. I thought there was an upper limit on the number of treatments you can get.
Nope. No. I think it's the upper limit is A, how much you can stand, and B, how effective is it? I mean, if after 5 sessions nothing's happening, then I call it quit or so, you know. If you're sicker than a dog and you can't get out of bed, then you got to look at that quality of life issue. You know.
The only drug I know where there is an absolute limit is radium-223, you know, Xofigo. Bayer will only dispense 6 lifetime dosages.
Aren't they doing a clinical trial for more?
They are. They definitely are. But right now, Bayer will not.
Yeah, that would be the next thing that I would go to when the the chemo fails. The big concern there is how compromised my immune system is. The guys got me on these white cell injection builds up for 7 days after each infusion.
Yeah.
My white blood count seems to stay around 6, and I guess it's supposed to be 10 or something like that.
The absolute neutrophil count or what white count?
I'm sorry?
You're talking about the absolute neutrophil count, the ANC, or what?
No, just the white blood count.
Just the whole, it should be at least 3,000, and the absolute neutrophil count should be about 1,000.
Well, there's something that shows a number of 6 of 1,000 or some percentage of 1,000 or some number of 1,000, yeah.
Well, I can tell you, having been on both Taxotere and radium now, the radium has to me, again, it's very individual, has far fewer side effects. It really does. The radium, and it really reduces the bone pain, and quite happy with it. And
I've had no bone pain, knock on wood. But so we'll see. How many sessions have you had of 223?
I've had 2, and I'm supposed to have the 3rd one today, but I decided, because I'm having a family Thanksgiving thing this week, I want to just take it. I have to watch where I pee and everything else, so I decided to postpone it by a week. It turns out you can't, for the first week or 2, you pee radioactive, and everybody freaks out and so on. So.
I guess you can't. Can you hold your dog after you've had that the day before or something?
I certainly can. She doesn't seem to mind.
Okay. Thanks, guys.
So, just one thing.
Is that an injection or an infusion of the radium-223?
Injection.
It's just a quick infusion over about a minute or so. They start an IV and they just infuse it over about a minute. You don't feel anything. You just go home and that's it. You've got to kind of have precautions around, body fluids and so on for about 10 days to 2 weeks.
So, Steve, I just happened to get my own blood work done this week, and I'm looking at the Kaiser report, and there's something that says white blood count, and the range is 3.5 to 12.5 K/UL.
Yeah, that's a 3.5. Yeah.
Yeah, so that's your white count, and that's the range. If it goes below 3,000, they do an automated white count, and part of that is called an ANC, an automated neutrophil count. You wouldn't do it if you didn't have a low white count, but when they do it, you're not going to get chemo or radium or anything else if your absolute neutrophil count is below 1,000, which is the number. On your differential says PMNs, polymorphonuclears. It's the percent of those in your total white count. That's the real critical thing in terms of infectious concerns. Okay. So the ANC you wouldn't even see on a normal white count. It only triggers if your white count's below 3,000.
Okay, and Ron, so what we're missing, and I now see, is it says 7.9 K, so the K stands for 1,000.
Yes.
Okay.
So I'm at 6 point something. Yeah.
So you're at
6,000. That's a fine white count on chemo. That's a great.
Yeah.
Okay.
Yeah.
Well, I think that's because I'm taking these shots and stuff. Because when I got pneumonia, my white blood was like 1.8 or 2 something, and they were freaking out,
Yeah. Right.
Okay. Yeah. Well, we're going to move on, if we may, and Paul Hobson, tell us why you are you're in the middle of a kidney test right now.
I'm about to go on a clinical trial, and one of the things that they want to test before they'll let you go on the clinical trial is your kidney function. Mm-hmm. And so what I'm doing today is they put a nuclear tracer in, and then after 2 hours, 3 hours, 4 hours, they're testing how much of that trace has been dispersed by doing blood tests.
Mm-hmm.
So that's why what I'm doing, and it's good to be able to listen in whilst I'm just sitting around waiting for time to pass.
Ron, could you mute? Would you mind muting? Thank you. Thanks a lot. Tell us what this trial is. Is this the lutetium, the PSMA trial?
It's the lutetium 177 trial, yeah.
Mm-hmm.
Which is what's happening with that is that they target the prostate cancer cells express a protein, PSMA, and they can target that with an isotope, and they also send down with the isotope a payload of a radioactive material, which is the lutetium, so that you get the radioactive material sitting alongside the prostate cancer cell, and also a fairly low emitter, so that it will kill the prostate cancer cell, but it doesn't damage the healthy cells too much. And it will also, unlike radium, which just goes to the bones, with the PSMA, that is both, visceral metastases as well as bone metastases.
Mm-hmm. And when are you hopeful that you will start, and how many sessions does it include?
I've got a few more tests to do. I've had a PSMA PET scan as part of the thing. They want to identify whether you express sufficient PSMA to be on the trial. Some people don't express much PSMA and are PSMA negative. They're also doing a sodium fluoride PET next Monday, and hopefully after that I'll know whether I've passed all the eligibility requirements. The treatment is up to 4 sessions with the lutetium, 6 weeks apart, depending on the results. Some people who've had very good results, they've stopped after 2 treatments, and there is a possibility that they will do further treatments down the track. The results so far are showing that whilst it can produce quite a good remission, it's not a permanent remission, and the cancer comes back. But they still don't know long-term sort of outcomes or side effects. This is a fairly early trial.
I mean, for those of you who are just wondering more about what this test actually is, it's in the same vein as the radium-223, but it is more refined in that the radium-223 is attracted to calcium, and you have a lot of calcium in your body, so the radium-223 basically goes to places that need it and places that don't need it, whereas the PSMA is very specific to prostate cancer cells, and so the lutetium is getting taken to the prostate cancer itself. If that's at least that's my understanding of the benefits of the PSMA, of the PSMA trials. They're doing them with a couple of different radioactive agents. Anybody want?
A few other spots.
This is phase 1 trial.
So there are a
phase
few
2.
other spots. Phase 1.
Phase 1. Go ahead, Paul. There are a few other spots.
There are a few other spots that in the body, apart from prostate cancer cells, that express this PSMA protein, but for instance, the salivary glands, but they express it at much lower levels. So
Mm-hmm.
it's quite easy to distinguish on the scans which is prostate cancer cells and which are the other known parts of the body that express this protein.
Mm-hmm. 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 Okay. Anybody else have any questions? Any other questions? Well, Paul, we hope...
Rick, no questions. This is Len. Just want to let you know I had to join the call by telephone because I wasn't getting any audio on the go-to meeting.
Oh. We're doing okay on audio here. Everybody...
Oh, no, I'm sure it's my computer. I've had lots of problems.
Oh, okay. Well, welcome, Len. Let me keep going through, and then I'm going to go in, and we've got some new people that I haven't checked in with, which I want to do. Let's move on to Ron and Susan, who just returned from a phenomenal tour of the national parks out west. And
yes, it was.
Go ahead.
It was glorious. And the weather couldn't have been better. It was 67 degrees, sunshine. I mean, it was amazing. I got a nice tan while I was out there.
Good. Good, 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 good. And which was
now,
the most...
The hiking...
Which was the most impressive park for you?
I liked Capitol Reef.
I see. I don't know that one.
It's a less traveled place.
Yeah.
There's nobody there, and it's so quiet you can hear the jet planes 7 miles up.
Is that right?
Yeah, yeah.
Is that right? Okay. Well, from the pictures I saw, it looked like you had a terrific time, and do you feel good?
Yes, I do. The only thing that was bothering me were my feet, and it might be the year and a half of docetaxel and all that other stuff, and carbotaxel, because my you get that numbness in your feet. Feels like I'm walking on rocks barefoot.
Yeah.
Yeah.
Yeah, yeah, yeah.
So other than that, I was fine. It was scary. Some of the hikes were scary.
Not compared to Angel Landing.
Right. No, we didn't do any Angel Landing.
I was just going to ask you about that, because that challenges you a little bit. That Angel's Landing in Zion.
Zion. Yeah, yeah. We did all the easies.
Okay. Good. 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 Good.
Yeah.
Well, I'm glad you had a wonderful time. Tell us what's on your mind.
Well, I'm on Xtandi, and while I first started Xtandi, I knew I was coming to the end of my regimen of treatment. So we went over to see Dr. Antonakis over at Johns Hopkins.
Right.
And he told me all about the AR-V7 test, blood test. And he said that if, he says, go on the Xtandi, do what you can, and as soon as your PSA goes up on 1 point, call me and I'll give you the test. And the test is supposed to tell me what route I'm supposed to take. He says like 30% of the guys are positive for this variant, and they have to take these 2 high doses of IV doses of these steroids. I wouldn't even begin to try and pronounce them, but they all end in MAB.
Right.
And then 70% of the guys are negative, so I could continue with the standard of treatment, which would be Xofigo, the radium. And then after that, I go into a trial for, I would take IV Listeria vaccine and some other drug. I can't even read it. The name's so long. So, well, my PSA, after I left Dr. Antonakis, went from 27 to 15, and then the next time it went down to 12, but then it started coming up, and it went up to 14. And I said, well, I'm still doing good. And then we went on the trip, and then when I came back, I just had the last one. Now, I don't know if it could be because I was sitting on my posterior for 10 hours in an airplane, counting both ways, and driving 1,700 miles. I'm sure that could raise your PSA. It went up to 18. So I'm thinking of contacting Antonakis and seeing what's going on. And my local oncologist, last time I spoke to her, said, well, I'd like to try some of the older, and I'm not sure what she means by that, chemotherapies. I've already had docetaxel. I had carbotaxel first for a year, and then they tried, when that quit working, docetaxel, I had it for like 5 treatments, and it didn't do anything other than take all my hair away. But now my hair's come back nice and wavy. Yeah, several women on the trip in Utah kept saying, "Oh, what wonderful hair you have." I didn't want to get into the story of how I acquired this hair.
So, there are some other drugs that are out there. There are some other chemotherapies that are out there. And she may well be thinking about the platinum-based chemotherapies.
Okay.
Cytoxin, Rick, has a resurgence as well. I think when she says old, she's probably talking about Cytoxin.
Cytoxin.
Is it going to take away my nice hair?
Cytoxin does, yeah. Yeah, I think it does.
Oh, bummer.
But I think that's had a resurgence in the last several months, it seems. There's somebody on the call that's been taking it as well.
Cytoxin?
Oh.
Let's see if I can...
The very old drug, a very old chemotherapeutic.
Let's see if I've got anybody. I haven't made a note of it, so I don't know. I mean, what I was going to say is that you can talk to. I would definitely meet with Antonakis again.
Yes, I intend to. Yeah.
And I would be talking to him about the chemotherapies. Find out from your local lady what she wants to give you, and discuss chemotherapies with him.
Okay.
The listeria vaccine is definitely something we know about because Jim Harrington has been looking at that for about a year and considering going on there. And it is a trial that's being conducted, and it may have some weight, which we just don't know.
Correct.
Whether or not to test you for ARV7, you got a response to the enzalutamide for how long were you taking it?
I'd say just about 3 months, and that's it.
Well, I mean, some people, that's all they get out of it. And then they start to come back, but then they may also respond to abiraterone. But, I mean, the one thing that I really want to encourage you to do is to get your tumor sequenced.
Yeah, I got to do that. I got to go. I talked to my urologist about doing another biopsy. I said to him, how much does that cost? And is the insurance going to cover it? And he didn't know any of that stuff. He just does the work. The billing out front, he says, knows how much it costs. So I think, I got to get you want to get new samples, correct?
That's right. Yeah, you do. Yeah. You definitely want to get new samples.
And originally, the whole right side of the prostate was involved, and it just creeped over one spot on the left side. So I probably have a couple of sites done on the right side. That would probably be the best way to, I think, to get the sequencing.
And you also have spots in your hip, correct?
Yeah, I don't know. I don't think I like that idea of going into the bone.
Well, it's certainly something again to discuss. First of all, you've got to get a doc in line and probably Antennarakis to do the gene sequencing.
Right. Oh, okay.
If they do the gene sequencing at Johns Hopkins, which they can do, it's going to take a little bit longer, but you know you're fine. That's fine, and they'll also decide. You can discuss with them where they want to take the bones, the sample from.
Right.
And it may be a hip, and it may be the prostate. Since you have your prostate, you should certainly suggest it. A lot of times they don't even consider that.
Right.
But from the people that I've spoken to who have had samples taken from bone, you know, they just say it's not a big procedure. Eric, did you have a sample taken from the bone?
No, I did not.
You didn't.
No, mine was done original tumor.
Right. And I don't know that there's anyone else on here that's had a sample taken from the bone. But
well, if they put me in La La Land and then tell me, oh, it's done, that's okay with me.
Well, that's what they'll do.
Okay.
That is what they'll do.
And I am having a little. I did have a little uptake in my latest bone scan. Nothing showed up on the CAT scan. The person who read the CAT scan said there's no definitive increase in metastasis on that, but there was a little uptake on one of my ribs and my scapula. But I have no pain and nothing. I feel great. As a guy in my support group locally, he's 93 years old. His PSA is like 123. And somebody said to him, how do you feel? He says, I feel so good. I need a twin to share this goodness. That's how I feel.
Damn, I just see we had a new guy on here that I was about to get to and we lost him, so hopefully he'll come back. I didn't know who he was, Henry Mack. Well, all I can say is go see Antennarakis.
Right.
And I think that it would be a really smart move to get that tumor sequenced.
Okay. Okay.
Anybody else have anything they'd like to add to?
No, I think just the same old discussion around gene sequencing, tumor sequencing. I tend to look at it as always a positive thing. I actually had circulating DNA sequence through Foundation One, and they came up with 2 mutations, neither of which were added any treatment options, and both are associated with poor outcomes, so it did nothing to really enhance my care. Admittedly, that's a smaller panel, but I think we look at it as if, gee, you get your tumor sequence and they're going to come up with all these new ideas, but that's not necessarily true.
Correct, yeah. Now, I did see that. Did you guys see that program about Watson, the IBM computer?
No.
And
no.
A whole bunch of doctors. Go ahead.
I am familiar with what they're trying to do with Watson. I was actually in a meeting a couple of years ago and sat next to the project manager, and you know that they're using prostate cancer as one of the diseases to try and program it.
Right, and what they're doing is they taught it medical language, and they say there's 8,000 papers printed every day on cancer. Watson can read 25,000 in a week and digest them. And when the doctors sit around and discuss a person's case, they ask Watson for his advice, or machine's advice, and most of the time the docs are right on. But 30 times Watson came up with some treatment the docs didn't even know about, and when they read about it, they said Watson was right on. So it's help.
Okay. Is that why they call the machine Dr. Watson?
Yeah, I think it is. I think it is.
Okay. All right. Well, look, I want to just touch base with the people that came in later on the call, and that's so we're going to move on. But please get that tumor sequenced. Do whatever
Okay, I'll
you've
talk
got to do. Okay.
All right, I'll talk to Antarakis. Thanks,
Okay.
Rick.
Bye.
Bye.
So we've got Len, we've got Paul, and who else? Somebody just came back on. Who else has not identified themselves or would like to identify themselves who's on the call right now?
Tebow. I joined about 40 minutes ago.
Hi, Tebow. And anyone else? Okay.
I think Len Sierra is not caller 8, Rick.
Len is caller 8.
I believe.
Okay.
I believe so.
So starting with Len, who's been doing God's work today with one of our more recalcitrant members. Anything you'd like to report or talk about, Len?
Yeah, this should just be very brief. I'm just curious to know, Rick, if any of the guys have ever heard of a medical oncologist recommending only 3 months of ADT following radiation therapy, which is, I think I may have told you, Rick, that was the recommendation from my med-onc at Sloan Kettering. I just finished radiation, 48 sessions of IMRT in September, and he said, okay, I think we'll give you an injection today, which was just a week ago, of Degarelix, and then starting next month, you'll be on drug holiday. And I said, isn't that a bit short? Shouldn't we go longer? And he just said, well, we really have no data on this, but, you know, I'm comfortable with it. So I was wondering, and when I accompanied Michael Seidman today to Sloan Kettering for his discussion of his upcoming radiation with Dr. Zalewski, Zalewski told him he would put him on a minimum of 18 months ADT following his radiation. So that's my question. Anybody hear of just 3 months? Or even 6 months?
Well, just a couple of things. What is Seidman doing right now?
Well, he has finally, after nearly 8 years of sitting on the bench with prostate cancer, he has finally decided that he is going to go forward with 28 sessions of hypofractionated IMRT.
Okay.
He's a very curious case. Okay. He said that he had 4 positive cores, 1 Gleason 6, Gleason 7, Gleason 8, and Gleason 9. Isn't that weird?
Yeah, I mean, I don't want to get so much into Seidman. The reason I asked that question, I mean, Seidman can come on and he can talk to us about his situation. I want to talk about you. And what I'm getting at is Seidman has never done any hormone therapy, right?
That's correct.
So there's a huge difference. You've been on hormone therapy for how long altogether?
Over about 22 months.
Okay. So it isn't like you haven't had hormone therapy. I mean, yes, they're going to give him 18 months of hormone therapy. That makes sense to follow up because this is his first lot of treatment. In your situation, you've been on hormone therapy, then didn't you stopped and then you restarted, didn't you, Len? I can't remember.
Yes, you're right, Rick.
Right.
I did. I've been on hormone therapy now for the past 12 months straight.
Okay, so maybe it's time to do another intermittent, and maybe that's what he's saying. Let's follow it up with a little bit, and then let's go back intermittent. You're not. Okay, you're not in the same. You're really not in the same category as somebody that's never had hormone therapy.
Okay, I understand what you're saying, and I was wondering about that. So Okay, that helps me understand why he only suggested 3 months would be okay.
So, what's the latest PSA?
0.11.
Okay, well, which is great, because before you, what was it before you started
For the radiation?
Yeah.
It was 0.4. Yeah, 0.4.
0.4. Okay, so so what you've seen is that and you were doing the hormone therapy. So the hormone therapy has been active right the way through your radiation. The radiation's had some impact because it brought it down just a little bit. What I think your doc is saying, Danila, isn't it? That
yes.
What I think he's saying is that let's give you a little bit more and then take you off and see where you go.
Okay, yeah, I'm probably a kind of a unique case, having been on hormone therapy for so long before any real primary therapy like radiation.
Anyone else have any thoughts on that? And anybody else want to talk to Len about that?
Yeah, Rick, this is Bill. I was, I guess, similar to him. I went on Lupron, well, Permgon first, and then Lupron for quite a while before radiation. But total time that my radonc told me was 18 months, at least. Somewhere between 18 and 24 months. And his reasoning was that the primary studies on the duration were one study which was 12 months and another study which was 24 months. And he said to split the difference for a lot of patients, he'll recommend 18 months if they don't want to live with the side effects for a whole 2 years. But he recommends no less than 18 months. That was my radiation oncologist. So.
Yeah, I mean, I'm somewhat familiar with a bunch of those studies, and I've probably told this story before, but when I was in the middle of my hormone therapy, a study came out that said, oh, maybe you should do 3 years. And I went back to Mac Roach, who at the time was the chair of the department, and I said, Mac, they say 3 years. He said, look, some say 12 months, some say 18 months, some say 2 years, some say 3 years, but we haven't really tested one against the other. So you make your own decision, and now in the last 3 or 4 years, it seems like they're moving to slightly shorter, and I usually tell people, if you're going to do it, figure that you're going to stay on for at least 18 months. But, I'm not a doc. It's probably what I would do. And I think 18 months is probably a good number.
Oh, shit. Rick?
Yes, Ron.
I was on hormonal therapy for 4.5 years. I mean, for me it was great because it lasted 4.5 years before it failed. Right. So I was thrilled.
Right. Right.
So I have 2.
So, everybody's a little bit different. I mean, Ron was on there, I think, if I remember correctly, for recurrent disease. But when you're going in for, when you're doing it for primary purpose, like Mike is doing it now, 18 months, or like Bill, 18 months seems a reasonable number. And, Len too, but like Len is a strange case because Len, you didn't want to get any more aggressive treatment. We had to work on you for a long time to get you to go with Boris.
Yes, you did.
So,
Rick, I wanted to ask Bill. Bill, you said he recommended 18 months, but was that 18 months total or 18 months post-RT? Because you just said you were on hormone therapy for a long time before your radiation.
Bill? We might have lost Bill.
Did you understand what he was saying, Rick?
Yeah, my understanding was a total of 18 months.
Total. Okay.
And in my case, it was a total of 27 months because I started it before.
Right.
So it was from when I first went on it. So
okay.
It's just the good and the bad. When I was in practice, we used to use a lot of Lupron for benign diseases like women with fibroid tumors of uterus or endometriosis, and we would just stay on for 9 months period because of the concerns about osteoporosis and pathologic fractures. Now with men, those things are less likely than women, but the longer you're on it, the more there's going to be a higher incidence of osteoporosis and fractures, and so now people are certainly taking some of the biphosphonates, the drugs to improve bone health, but even with that, being on it 2 years or 3 years or something is, I mean, on the good side, you're fortunate enough to be alive. On the bad side, you're standing a significant risk of bone fractures. So, I don't know.
But then I just have to add that that's the reason why we encourage you to exercise, because that is one of the ways that you can mitigate the impact on your bones by doing exercises, weight-resistant exercises which stress the bones. It helps. Is that's fair to say, right, Steve?
Yes, absolutely.
And which reminds me, some of you have promised to sign up for the MAN plan, and we actually had one person who made a call in the last week and is in the MAN plan. Ron, didn't you sign up?
I did. I signed up, and I got my package, which is very nice, and I talked to my lady contact there, and then I broke my elbow.
Oh, you broke your elbow. Oh.
Yeah. So I fell and broke my elbow, so I wasn't able to do anything, and they've been really good. They've called, and I think one time they talked to my wife, and she said, until he can start using his arm, which basically this last week I've started being able to use it more. So, so anyway, all I can tell you is that they're really great people. The package they send is very clear. You watch it on the video, and they take you through each exercise. They've got a stretcher thing that comes with it. So I'm anxious to get started.
Okay. All right, Tom Van Zandt.
Hey, this is Dennis. I've been on it too.
Okay. And how are you doing on it, Dennis?
I've graduated from the beginner level to the intermediate level.
Great.
And I'm halfway through that and making all of the reps and sets and everything that was recommended. So I do feel stronger.
Yeah.
This is after the chemo. I was just extremely weak, and they told me it would take several months. So doing this has helped. It's helped my golf game.
Good.
I'm out driving all my partners, and they've been accusing me of taking steroids, and I said, yeah, well, I had to take them with my chemo, so.
Okay. Now, Tom Van Zandt, are you listening, Tom Van Zandt?
Yeah, I'm here.
Never mind you're here. Didn't you sign up for your package this week? See, we get good results when we do it.
I did. I signed up and I got a phone call back, but I haven't received anything yet.
Okay. Well, you've got some brothers here in Ron Shaheen and Dennis Correa, and hopefully Jake Hannum, who I'm trying to get to sign up.
I'm in it as well, Rick.
All right.
I've just started the intermediate. This is Jeff.
All right, Jeff. Okay. And are you enjoying the program, finding it helpful, finding it useful?
Yes, absolutely. I've got some shoulder problems, and it's helping with that.
Good. Mr. Hannum, did you call him yet?
No, I didn't call him, Rick. I did look into it a little bit, and I saw that they call you. They want your phone number so they can call you and counsel you, quote unquote. And I just hate phone nags, so that's the main reason I haven't called yet.
Guys, any of you guys want to comment on that? Who are doing the program?
Yeah, I've got a couple of calls from them just to see how I'm doing. And I did have to call because I first time I tried using the intermediate, the green band, it broke in half on me. So I called for a new one. That was about a week and 10 days ago, and she said she would send me out a new one. So in the interim, I'm still using the beginner level band for some of the intermediate exercises until I get my new one.
Well, you are obviously a star, Dennis, because you got so strong from the first lot that you bust the band right off the bat.
Right.
Jake, I think you got to trust them a little bit. I know it's easy to say and hard to do, but I do think that they know, that they're supportive. They're not going to bug you, and we got 3 guys who are all positive about the program right now, and there are more I know that I've referred. So
I'll take another look at it, Rick.
Thank you. Okay. We're just over time. I just want to check in. Thibaut, everything okay with you? We may have lost Thibaut. All right. And Paul Frieda, how about you? Everything okay by you?
Well, as far as cancer is okay. I got my my close to 1 year shot recently, but my big problem is my back went out and I'm wearing a brace now to keep the pain down. My lumbar just went out when I was on the tennis court. Other than that, everything's fine.
Oh. Okay. And somebody else joined us right at the end. I don't know who it is, but I just want to acknowledge that I try to keep an eye out. I missed one guy who I don't think had been with us before. I apologize. And we've really come to the end. So whoever else is on there, if you haven't been on here or you haven't spoken up before, come back and visit with us on Monday at 8 o'clock Eastern time. And for sure, if you're here at the beginning of the call, you'll get plenty of time to talk. So, guys,
Rick,
we'll
can I make
sign
one
off.
Can I make a suggestion? Can I make a comment? This is Jake. First of all, thank you for getting that copy of the Foundation One Act, the blood biopsy one. Thank you for getting that. I was hoping it's a little bit over my head, to be honest. And I was hoping maybe you could discuss it and tell me what you think of it in a future date. Not tonight, of course, but
Yeah, thank you for reminding me. I was provided by Foundation Medicine as a follow-up to the plenary call a couple of sample reports. If anybody would like those reports, I am more than happy to email them to you. I haven't decided whether it's appropriate to post them on our website. I just don't think so. But I do have them, and we can talk a little bit about the reports. Hopefully, Steve will be on when we do that because he's gotten a report himself. But I'll get Professor Bill on when we do that. We'll do it in the next couple of weeks. But thank you for reminding me about that.
My gut reaction to seeing it, again, like I said, I don't understand all the terminology, but my gut reaction was that it's probably not going to be real helpful. It's not. I don't think it would be very helpful for me. So,
you may be a little early in the process, Jake, but I think that it can be incredibly helpful for somebody like Ron Silverio, who we keep encouraging to do it because he's been through so many different treatments. We need to see what the genes are that are giving him grief. So, okay. Well, I'm going to sign off. Len, I'm going to give you a call because something came up earlier in the call that I just want to chat with you about before.
Sure, no problem, Rick.
Okay. All right, guys.
One last comment. I am now a 2-year survivor.
All right.
As of 5 days ago. So,
Congratulations.
And I'm feeling good.
All right, all right. Guarded or not
Have a good
guarded, we
night.
hope to see you in another 2 years.
Thank you, Eric.
Okay, bye. Bye-bye.
Good night. Good night.
Good night, guys. Thank you, Rick.
Hi, guys.